Hello, everyone. I am Dr. Dionila Dumanon. I'm a third-year Otorhinolaryngology head and neck surgery resident at Western Visayas Medical Center, and I am tasked to discuss briefly on your basic ENT history and physical examination. So these are my references, and these are our outstanding consultants who made ORL HNS possible in the Western Visayas chapter. Welcome to your online block 10 or your special census, and sit back, relax, and I hope you will learn a lot from this lecture. So in ENT, taking history is quite similar with general medicine, pediatrics, and adult medicine. Of course, it is important to ask for the OTQRFT, which is the onset, provocation, quality, radiation, severity, and also the timing. What makes ENT special is that the physical examination is something that we did not get to do or get to encounter often during our earlier days in medical school. So it would be nice that you get to experience it firsthand. But for now, I hope we all would use our imaginative mind in performing the proper way of ENT physical examination. So we have a total of 6 ENT PE as listed, and we will be learning about it today. Okay. So what are the materials that we need? So we have a 100-watt gooseneck lamp for our light source, which is situated on the right side of the patient. And next, we have an ENT chair. It is in which the height can be adjusted, and also the backrest and the leg rest can be stretched, so you can create a full supine position. We also have a head mirror. This is very important and must be properly positioned on the left eye of the examiner, and the examiner must see through the hole of this mirror and also use it to reflect light towards the site to be examined. So if the gooseneck lamp is on the right side of the patient, the head mirror is situated on the left eye of the examiner. Next, we have the otoscope. So an otoscope with an oral speculum. So as a student, it doesn't matter what brand you use, as long as you hold it properly and you use an adequate size oral speculum. The maximum oral speculum that can fit inside the patient's ear canal is the right one to use. So next we have the nasal speculum. It's also very important to visualize the nasal cavity. So there are different sizes of this one. So, and then next we have the laryngeal mirror. We have a number 4 laryngeal mirror for indirect laryngoscopy, and we use a smaller size mirror, a number 0 mirror for the posterior rhinoscopy. Also, we have the tuning fork test. We have its foot piece, its stem, and the prong. So this 512 Earth tuning fork is used for the tuning fork test. So it is definitely part of your basic ENT physical examination, especially for those who come with hearing disturbances. And lastly, the most important of all, with or without the pandemic, we have to use the appropriate personal protective equipment, such as the face mask, face shield, and gloves. So proper position. The examiner can examine the patient in standing or sitting position, as long as the examiner is of eye level or just above eye level of the patient. So once the patient is seated on the examining chair, make sure to instruct and position the patient in an upright position, legs uncrossed, and keeping his or her back straight. The light source is positioned just posterior to the right shoulder of the patient. Okay. So before we start, I'd like to remind everyone to always be polite. So before you examine any patient, introduce yourself. I am clinical clerk, or I am a medical student, and I'd like to examine you. You ask permission before you touch the patient. You have to tell him or her that what you are about to do, so that the patient can anticipate what you are going to do to him or her. Okay. So let us go to our first case. We have case number 1. An 8-year-old boy came into you with a decreased hearing. So what would you like to ask? So we'd like to ask, when did the decrease in hearing start? The duration, which ear is affected, or are both ears involved? Does the hearing get alternately better or worse? Or was the onset associated with other illness or use of medication? Is there any family history of decreased hearing or hearing loss? History of surgery on the affected ear? So what social, occupational, educational handicap does the hearing loss produce? So what are our differentials for this case? We can think probably of infection, such as otitis externa or otitis media. You can also think of foreign bodies, such as cockroach, pellets, or seeds. Then maybe an impacted cerumen or a conductive hearing loss. But for this one, if you have a PE of this one, this is actually an impacted cerumen. So I'm just not sure if it is the right ear or the left ear, but definitely it is an impacted cerumen. So how are you going to do the otoscopy? So we have, we need our gloves, otoscope, adequate size oral speculum, and the pneumatic bulb if available. So it is important to hold the tina properly. For adults, we are to pull it superior and posteriorly, but for pediatrics, we are to pull it posteriorly and inferiorly. Notice how the examiner is holding the otoscope. So, and the anchorage of his right pinky finger on the right cheek of the patient. If we are to examine the right ear, we are also to use our right eye in viewing through the otoscope. But I'd like you to remember that before you examine the ear canal, make sure that you also inspect the outer ear. So inspect the tina, if there are any mass or any hematoma or any erythema or anything that you can see which is not normal on the ear. So sometimes we tend to be so excited that we want to see the tympanic membrane that we forget to examine the outer ear. Okay. On the left ear, the same procedure is done on the examination, but take note that the left hand is used already to hold the otoscope. So, and viewing through the otoscope, we are to use now our left eye. As you can see in the rightmost photo, as shown in as pointed by the blue arrow, this is used to check this is what we call as the pneumatic bulb. So we use this to check the integrity of the tympanic membrane. So a light pressure is given using the bulb, which will cause movement of the tympanic membrane if it is intact. So if you do not have such equipment, you can let the patient pinch his nose and with a closed mouth, let him or her swallow. So, or you can do the Toynbee maneuver. So before we get to know what is abnormal, we also have to know what is normal. So in a normal tympanic membrane, we can see a clear TM with a cone of light. You can also see the umbo, the handle of the malleus, and the pars flaccida. Like doing T in other parts of the body, we also divide the tympanic membrane into 4 quadrants. So, namely the anterior inferior, anterior superior, and posterior inferior, and posterior superior. So, the cone of light is usually located on the anterior inferior part. So, on the photo on the left side, you can see the right ear. You would know that it is the right ear because of the direction of the handle of the malleus. So this one. If it is directed towards the right, then it is the right tympanic membrane. But if it is directed towards the left, it is the left TM. But however, some would say that the cone of light is also a good indicator for the laterality. But actually, the cone of light can be an indicator. However, not all TM are intact. So if in cases of perforation, we cannot identify the cone of light. So, but if it is an intact TM, it is safe to say that if the cone of light is located on the anterior inferior on the right, then it is the right tympanic membrane. But if it is located on the anterior inferior on the left, then it is the left TM. Okay, so here. So this is an example of a perforation. So each quadrant of the tympanic membrane, as mentioned, it is actually equivalent to 25%. So if we report this case on the left, we can see that tympanic membrane has approximately about 15 to 20% central perforation located on the anterior inferior, more on the posterior inferior quadrant. Okay. On the left photo, on the right photo, this one, it has a bigger perforation. And by dividing it into 4 quadrants, you can see that it's about 45 to 50% perforation on the right ear. So located in the anterior inferior to the posterior inferior quadrant. So part of examining the ear is also doing your tuning fork test. So how are we going to do such test? So for the Weber test, we strike the prong on the palm of your hand, a 5-1/2 tuning fork, or you strike it on your elbow and you place it at midline so you can hear it, the vertex. You let the patient tell which ear he or she can hear better in the sound. So if the patient hears it more on the right, you'd say Weber right. Or if the patient can hear it more on the left, you document it as Weber left. But if the sound is at midline or equal sounds are heard on both ears, we'd count it as Weber negative. For the Renée test, we instruct the patient to tell you if he or she cannot hear the sound anymore. So just make a sign if he or she can't hear it. So after striking it on your elbow or in your palm of your hand, you place the base of the tuning fork as shown in the photo on the mastoid tip. If the patient cannot hear it anymore, you transfer it. So the bone conduction, if the patient cannot hear it anymore, you transfer it opposite the ear canal, about 1 inch distance as shown in the photo. Then if the sound cannot be heard, then the patient will tell you. Okay. Then do it also by doing it first on the ear canal and then you follow on the mastoid tip. So if the sound is, if you place the tuning fork on the mastoid tip and the patient should no longer hear it, but when you transfer to the ear canal, but the patient can still hear it, so that means that the ear conduction is louder than the bone conduction. So we call it as Renée positive. However, if the sound is placed on the ear canal and cannot be heard anymore, but when you transfer it to the mastoid tip, the patient can still hear it. So we'd call it as Renée negative, or bone conduction is greater than air conduction on the tested ear. Okay. A further discussion will be done for this on your ecology lecture. Ear flushing. Ear flushing is also an important skill that we must learn during your ENT rotation. Or if you are to flush the right ear, we usually use a kidney basin positioned just below the right ear, and a towel is placed on the right shoulder of the patient. So a metal syringe, or we usually use a 10 cc syringe connected to the plastic cannula of an IV cannula gauge 18. Make sure you do not flush if the patient has perforations. How will you know? So you ask the patient if it's a chronically draining ear. So definitely it's a no-no. If you visualize that there is really a perforation, then definitely you're not to do it. So when you direct the cannula towards the ear canal, do not puncture the ear canala, so as it is very thin and can be easily violated. So the goal is, if there's a foreign body inside or if there's an impacted cerumen, the goal is to flush water inside, and the water that returns back will push the water outside. So, okay, now we're going with our head and neck. So, a 38 years old male came into you with an anterior neck mass. So, what would you like to ask? So, when did the mass start to grow? Is it chronic or rapidly growing? Also, another one could ask, is the mass slowly growing or not rapidly growing? Is there any episode of decrease in size? Is it associated with compressive symptoms such as dysphagia? The consistency of the mass, soft, firm, hard, or has it always been soft, or has it always been firm? Is it associated with hoarseness, any weight loss. So what are our differentials? There are a lot of causes of anterior neck mass. So for this case, you can think of a benign thyroid mass, multinodular non-toxic goiter, non-nodular non-toxic goiter. You can also think of malignancy. So it's a papillary thyroid carcinoma, which is very common, follicular thyroid carcinoma, squamous cell carcinoma of the thyroglosal ductus, which is just 1% of the thyroglosal ductus na mass, congenital neck mass, such as bronchocleptis, thyroglosal ductus, which are benign masses, and then infectious, so it can be extrapulmonary in origin. So for this case, actually, this is a case of a squamous cell carcinoma of a thyroglosal ductus. So head and neck. So it is very vital to learn the different triangles of the head and neck. Also, learn the different levels of lymph nodes. In reporting any mass or lesion on the head and neck, it is important to identify it relative to the different triangles or lymph node level. So it is your assignment to read on the different triangles of the neck and lymph node level. So what do we need? We need gloves. So the also shepherd gloves, your examining chair. The examiner should be standing behind the patient and palpate gently from lateral to medial side and identify any possible mass or lesion. So upon reaching midline, while palpating the thyroid area, make sure to let the patient swallow so as to identify any mass that elevates upon swallowing. This can give you an idea that it could be thyroid in origin. So example, this one. This is if you are given a mass of this appearance, so we can say that there is a 2 by 2 cm round mass on the lateral neck left, lymph node level 3, firm, fixed, and non-tender. Okay, so always identify the size, the location, and the laterality, and its consistency also, and if there are any pain associated to it. Okay. So after head and neck, we are to go to anterior rhinoscopy. So a 14-year-old male came into you with anosmia. So what would you like to ask? So I'd like to ask, is the loss associated with trauma, upper respiratory infection, systemic illness? Is the loss or change of smell partial or complete? So is it on the right ear, right nostril only, or on the left? Is there history of sinus or nasal disease? So is the patient chronically with nasal itchiness, or there is tenderness on the facial area, or are there any other systemic symptoms? Fever can also be considered, especially now that it is the pandemic. The pandemic is not yet over. So we are to consider those patients who have anosmia because it is very common in COVID-19 patients. So what are our differentials? Pwede malignant, you can think of malignancy, benign conditions such as the nasal polyp, and also infectious. So for this patient, this is actually a nasal polyp. So how to do anterior rhinoscopy? So we need gloves, nasal speculum, head mirror, gooseneck nut. Also, you need a chair. So notice how the examiner placed his thumb on the hinge of the nasal speculum. So it is the proper way of holding the nasal spec. So as you slid inside, you use your left hand. As you slid it inside on the right nostril, make sure that the nasal speculum is closed. And when you slid it inside, you open it. You rest your finger at the tip of your nose or on the lateral side of your ala. And then you view, and then you direct the light from your head mirror towards the desired side or your right nostril. And then just before you remove it, do not close fully, just partially close so that you will not be able to clip any hair that is inside, so you won't be hurting the patient, and just pull it slowly. The same thing is done on the left nostril. The same hand is used also. Just use your left hand because your right hand should be free from for any instrumentation. So, what are we expected to see? You're expected to see the nose, the inferior turbinate, the middle turbinate, the nasal septum. So you just identify if there are any erythema, mass, discharges, or if there's any congestion. So it is also very important that you would know if it is a polyp or not. So how will you know if it's a polyp or not? So first of all, you have to identify it. So you have to check. There are polyps that would appear reddish. So what you can do, first you take the BP of the patient. And after taking BP, if the patient is not hypertensive, then you can proceed with nasal decongestion. So you decongest. And then after decongestion, if the swelling or any congestion inside decreases, then most likely it's just your turbinate. But if it is not decreased, then it has a pale grape appearance. And then when you focus with a blunt instrument, it is non-tender, then most likely it is nasal polyp. But because sometimes your turbinate can appear like your nasal polyp. So next we have case number 4, a 24-year-old male who came in for throat pain. What would you like to ask? So I want to know, when is the duration? Has it been days, weeks, months, or years? Is it associated with dysphagia or edeynophagia? Is it accompanied by fever, discharge, expectoration? Is there any pain? Any change in voice, muffled voice? What treatment has been given in the past? So what are the differentials? So for this one, you could think probably it's acute tonsillopharyngitis, viral versus bacterial. You can also think of a peritonsillar abscess. So usually a peritonsillar abscess, the uvula is already deviated towards the opposite side or the unaffected side. So this is our uvula. So there is swelling on the peritonsillar area. Also, you can think of a tonsillar mass. Okay. So how are we going to do the oral cavity examination? So we are to use our gloves, head mirror, gooseneck lamp, and also tongue depressor. So when doing your oral cavity examination, make sure you ask the patient if the patient has dentures. So he or she must remove the denture. Also, you are to have a gloved hand. Whether using a tongue depressor, you are to depress only up to the anterior 2/3 of the tongue, so as not to elicit any gag reflex on the patient. Then you are to examine everything that you see. In the oral cavity, there is actually 7 subtypes. You can read about it. The half, I call it half bra. So you have your hard palate, alveolus, lips, floor of the mouth, buccal mucosa, and then retromolar trigone, and then also anterior 2/3 of the tongue. So when you depress, you examine everything. You see the oral cavity and also in the oropharynx. So, and then you also do bimanual examination. So you palpate everything. If there is mass, you palpate it, and then you feel what its texture, its consistency, if there are any bleeding. Also note if the patient has dental caries. So this structure, what is this? This is actually the papilla of your sentence duct. It's opposite the second molar. It's opposite your molar. The right maxillary area. It is the opening of your parotid gland towards your oral cavity. So it is not an abnormal finding. It is actually normal, and you have to locate it. So you have to identify if it is obstructed or not. So in the oral cavity, you have to identify, as you've seen earlier, the tonsils was enlarged. So there are actually 2 grading scales for tonsils. There is a Friedman and then Brodsky grading scale. So for the Friedman, you can read about this one, grade 0, no tonsil scheme, 1 tonsils are in the tonsillar fossa. If it is beyond the anterior pillars, it's already grade 2. If it extends 3/4 of way to midline, it's grade 3. It's completely obstructing the airway, it's in tonsil. So other grading scale would be your Brodsky, which is quite similar, but it's using percentage. So if it's less than 25% grade 1, 26 to 50% grade 2, 51 to 75% grade 3, and more than 75% is already grade 4. So I've mentioned this earlier, the half graph. So, okay, next. So, a 34-year-old male came into you with a foul-smelling nasal discharge. So, you can see this one. These are the discharges. This is in the nasopharynx of the patient, and this is in the oral cavity. So, what would you like to ask? So I'd like to know the duration of the discharge. Is it accompanied by fever, voice change, cough? Is it discharge mucoid, purulent, or blood stain? Is the amount profuse or scanty? Is it coughed or spit up? Or is it first on arising in the morning? So what are our differentials? Well, we can think of probably upper respiratory tract infection or acute tonsillopharyngitis, malignancy such as nasopharyngeal mass. So how are you going to do your posterior rhinoscopy? So we need glove, tongue depressor, laryngeal mirror, and the gooseneck map. So the goal is to view the posterior of your the nasopharyngeal area or your posterior of your nose. So what are you going to do? You are to hold a tongue depressor, depress it on the anterior 2/3 of the tongue. You hold the number 0 mirror and rub it on the mucosa, buccal mucosa, or you can keep it with an alcohol lamp if available. And then by holding it like a pencil, you slid it inside, and as you reach the oropharyngeal area, you swipe it from right to left to examine and visualize the nasopharynx. So it is important that you have a proper positioning of your headlight at this time. You have to direct it towards the mirror. So it is okay if it is very difficult for you to perform this, but it's actually quite difficult procedure. But as you practice it more often, it would be an ease or so. What are you expected to see? So you're expected to see this one from the mirror. You're expected to see the septum, the soft palate, the opening of the eustachian tube opening, the tubal elevation, and the concha. So by doing this procedure, always remember when you are examining the posterior nasopharynx, when you're sliding the mirror, tell the patient to breathe through the nose. Okay, why? Because if the patient breathes through the nose, the soft palate of the patient will depress, and then because of the air, it will widen the nasal cavity, so you can visualize it more. Okay. So next, we have case number 6. So a 42-year-old female came in for hoarseness. So what would you like to ask? So I'd like to ask, when did this start? Was it sudden or gradual? Is the difficulty in speech increasing? Was the voice completely gone at any time? History of hoarseness in the patient? More prominent? Is it more prominent after long hours of talking? Is it are there history of alcohol ingestion or smoking? So what are the differentials? So we can ask for this one, we can think of benign vocal partition, or it could also be a malignancy. So a squamous cell carcinoma of the larynx, which is very common. And then we could also think of an infectious TB laryngitis. Okay. So how are you going to do your indirect laryngoscopy? It is important to As mentioned earlier, to ask if there are dentures, so let the patient remove his or her dentures. And then you instruct the patient what you are going to do. So you wrap around the tongue with gauze, and then you protect it with your finger. And using a number 4 mirror, as you pull the tongue using a number 4 mirror, you rub it on the buccal mucosa. And then as you slid it inside, holding it like a pencil, viewing the inferior part or the laryngeal structure. Okay, what are you expected to see? So can you see this one? This is an inverted image because you are using a mirror. So this is your vocal cord. So this is your left vocal cord on this side. This is your right vocal cord. So arytenoid. I'll give you a zoomed up picture. So this one. So expectedly, you're going to see this one. So these are your epiglottis, true vocal cord. This is your false vocal cord, arytenoid, epiglottic fold that connects your arytenoid and epiglottis. And this is your glottic opening. This is actually your tracheal rings already. So this is the adducted, fully adducted vocal cord. So it meets at midline. So what are you going to instruct the patient? So as you sit inside, and if you've already fully visualized the vocal cord, you instruct the patient to breathe, inhale and exhale, and then you let the patient say E, and then as the patient phonates, the vocal cords are expected to meet at midline, or they're expected to adduct. So if this does not happen, this is due to probably, if there are masks, then the mask is causing incomplete adduction of an incomplete adduction of the vocal cords. So that is why there is forces. So as mentioned, as case number 6, in case number 6, there are lesions on the vocal cord. So in reporting the vocal cords, it is important to divide it. If you see anything, you divide it into 3. So you can say, so this is the anterior, middle, and then posterior. So you're writing. If you see any lesion, you just write, and there is a lesion on the anterior third, or the middle third, or the posterior third. So you have to locate it. Okay. So in doing a rigid laryngoscopy, this is what you are going to see. So the normal appearance of the vocal cords is V position. So and then, so this one, I'll be showing you, actually this is a flexible laryngoscopy video. So this is passed through the nostril. This is the middle turbinate. And then as you move further, you can see the eustachian tube orifice here on the side. This is the nasopharynx. There are no masks noted on the nasopharynx. As you move a little further, you can see the epiglottis. And then you can see the arytenoid, bilaterally, false vocal cord, true vocal cord. There is a lesion on the middle third of the left vocal cord. Okay? So every time the patient phonates, though the vocal cords meet at midline, it cannot completely adduct because of the presence of the lesion. So this area is your piriform sinus. Also important to note if there are any pooling of saliva in that area. Okay. So lastly would be your cranial nerve examination. It is important to do your, I know you already know about this one, but it's important to master all these 12 cranial nerve exams because it is important in ENT because it is the site where ENT is, where is the site of the ENT or head and neck. Okay, so next would be your facial nerve grading system. So it is also important to learn about this one. grade 1 to 6. 1 would be the normal, and then last would be 6 would be total paralysis. So it's important. What is noted here is a normal function of the forehead, the eye, and the mouth. So very important to remember in this is number 3, grade 3. So if there is complete eye closure with effort, then most likely it's grade 3. But if there is an incomplete closure, then definitely grade 4. So it's always important to remember that. So usually asked also. So that's the last of my lecture. And I'd like you to remember always to be polite and always ask permission. So thank you so much for listening, and I hope you learned a lot from this lecture. Have a good day.